follow that same paradigm or that same kind of thought process of quality management, but we're going to move it from end-to-end testing and program management overall to kind of a more granular or a more detailed look at imaging. So, and we think about imaging, it's not just the simulation imaging, but it's also the image guidance. So whether it's film or whether it's onboard imagers, all those have uncertainties and things that they can offer to improve outcomes. So let's see. Okay, and I'm alone now, so I'm going to take off my mask. The initial conditions. So obviously, I'm from the States, so ASTRO and AAPM is kind of, these are my professional societies that I work with, but there are other ones, ASTRO and whatnot. And they're all over the world. There's good professional guidance documents. And obviously, the IEAE has a lot of great documentation. And I'll mention some of the documents that I referenced in the presentation. So, as an initial condition, you should be aware of the professional societies and the literature that they have to offer. So, some knowledge points we're going to talk about: quality, imaging for planning, and imaging for treatment. So, there are some good consensus statements from those professional societies that I just mentioned. There's an ASTRO Quality and Safety White Paper for IGRT in 2013. There was another Medical Physics Practice Guideline for IGRT in 2014. And just a few years ago, IEAE, kind of aware of the fact that more and more clinics are implementing IGRT on the machine, onboard imaging and whatnot, they had a document for introducing IGRT into clinical practice. And I highly recommend reviewing these documents and that IEA document in particular. So there are a large number of imaging technologies, and one of those, the ASTRO, gave an overview actually of the different AAPM task groups that have addressed imaging technology, whether it's planar KV, planar MV, cone beam, fan beam, all these different imaging. There's lots of, you're going to have your specific technology that you have, so you should focus in on what you've got and realize that there's resources for that. And there's also newer stuff, such as the surface guided image or radiotherapy, and this SGRT. These have different technologies, and you should be aware of what your system uses, whether it's scanning lasers or a speckle pattern. Understanding your limitations or your specific technology is important. So we talked about end-to-end testing last week, and we talked about how important it is to kind of get an overall idea of the uncertainty of your treatment chain from start to finish. So and we mentioned that last time, there's lots of different phantoms out there. These are some rando style ones. There's also the Lucy here, and you can even make your own with gel dosimetry, which does take some extra work, but is a rich area and well established. And there's if you're interested in doing an end-to-end, gel dosimeter is really a really important tool. So the imaging quality assurance, again, there's two different types of imaging that we're kind of talking about here. There's the imaging for the treatment planning, and then there's the imaging for the treatment delivery. And each of these have their own uncertainties. I think the biggest one is if you're using multimodality imaging, if you're using an MR and a CT or a PET and a CT, that registration and that fusion, the difference there and the uncertainty there, it's really critical to understand. And when I first started using more PET CTs in my practice, it wasn't always apparent to me, but because that PET CT is taken over a long period, the CT associated with the PET might not quite overlay with the anatomy. So just fusing the two CTs together may be insufficient to get a good matchup. It's really important to look at that PET in relation to the anatomy, and that can't be overstressed enough. We don't register with our eyes closed. Don't just use auto registration and assume it's correct. Even if it does do a good job, that doesn't mean that the previous registration was aligned properly. So being mindful of that is important. And then in treatment delivery, I think I may have mentioned this before. Focus on what counts. If you're treating the breast, it's the surface it's the actual contour that's important. If you're treating the prostate, it's that soft tissue that's important. So you can have the spine perfectly aligned, but the soft tissue may not be right where you want it. So you really got to focus on what counts. And then it's a refrain you may already be tired of, but is the uncertainty, acknowledging the uncertainty. This is one of the main things of physicists, is to understand the uncertainty in the process. So imaging in modern radiotherapy is critical, and here again we're showing that there's three different kind of sections. That target and normal tissue definition is important, and I think that's one of the largest sources of uncertainty in modern radiotherapy is in the variation in contours. And one of the ways to reduce that uncertainty is to have peer review. So having physicians checking physicians and making sure that they agree, and that contour, did they get all the nodes? Do you think that's an area? I've sat in a lot of physician peer review meetings, and there's often, every other meeting, there's going to be a call out, and it's going to be a discussion about whether or not the node should be included, or if the margins are sufficient to encompass, disease that's not visible. So that's really important, but getting that target defined well from the first start is essential. And this is, again, I'm sorry if I'm talking a little fast. I have had my coffee this morning. I am running around. So I'm gonna do my best to make sure that the flow is okay, but I'm gonna try and slow down. I think I've been talking a little fast. So there's two different philosophies of quality control, and they are complementary. So there's the one of prospective quality control, where you look ahead. So you do failure mode and effects analysis. This is looking at it before the error occurs, analyzing your process flow, looking for the weak pieces or the weak links, whether that could be protocol selection. Maybe we're using a suboptimal imaging protocol that doesn't allow us to visualize the disease as well as we could. And really, by looking at it ahead of time, we can focus our efforts. The other philosophy of quality control is retrospective, and this is traditionally how it's been done. When something goes wrong, we want to know why it went wrong so it doesn't go wrong again. And so if there's a new control measure that needs to be implemented, because engineering controls are the strongest. If there's something that we need to change in the process in response to an error, that's kind of how it's always been done. The hybrid approach is ideal. We want to mix these two things. We want to do our best to avoid errors before they occur. And if they do occur, we want to look at them as learning opportunities and grow from them. So a lot of this prospective stuff came out of Bell Labs, and it's a form of statistical process control. So this is a picture of Schuhart at Bell Labs. Most people know about Deming as being the one that kind of promoted this, but it did come out of Bell Labs. And what it was is, you don't know what's happening unless you're measuring it. Measuring something allows you to control for it. So if you measure a period of shifts over time, you can see what's expected, what's unreasonable, and what should be investigated. So you can use retrospective data to analyze your processes and determine if your margins are appropriate. Maybe I need to add a larger PTV margin because there's a little bit more variation than I expected or I had hoped for. Or maybe I can actually shrink those margins, or at least shrink those margins in the direction of organs at risk. Then you can also review if your protocol and other tolerances are acceptable. Is your image quality ideal? But if you don't measure it, you don't know. So just as clearly established planning objectives help ensure quality, so can IGRT objectives. So how far of a shift is acceptable, and what kind of guidance you're going to provide to the therapists, the technologists who are delivering that treatment. And this right here is showing what you're getting with different IGRT. So no IGRT. These were collected from a series of films. No IGRT, you see a displacement. You actually also see a systematic displacement. Offline IGRT, where things are corrected the film is reviewed and they're told, okay, we'll move it here. You get it a little bit better. But then online IGRT, where you're actually responding to the image and correcting the image before treatment, you're really able to dial in the positioning and really deliver a higher quality treatment. So part of the quality for image guidance is making sure that you are providing the therapists or the technologists with clear and actionable instructions, to use specific protocols or to align to specific anatomy. Not every anatomical location should be aligned to the same way. Just as I mentioned earlier, the prostate versus the bony landmarks. So giving that guidance and those instructions in a clear way is very important. And this was mentioned last time for continuous improvement. All this stuff is ongoing, so you should be reviewing this on a periodic basis. And why do we do this? Well, it's been shown that quality improves outcomes. There's been a couple of studies where they've looked at adherence to protocol objectives. So if anybody's done some clinical protocols, whether they've been RTOG or NRG, or at least followed those documents or used those guidance, some of them have really strict dosimetric parameters. Well, what they've shown is that protocol deviations correlated with survival. So the better they were able to meet the protocol, the better survival they got. And they did a meta-analysis of 8 trials showing this. And I think that there's some fair critiques about selection bias, like maybe that the harder patients were already had they were going to have a harder time. But I think it's pretty undeniable that adhering to the protocols has shown improvements in outcomes. So we should do our best to adhere to them and stay close to it, deliver as high a quality of a treatment as possible. Here's some other ways of kind of looking at it in terms of relation to outcomes. So from diagnosis to outcome, we've got many different interventions. We've got many different steps. And each one of those steps, and we're talking outside of just the physics realm, we're talking from the diagnosis to the staging to the contouring, and then actually the biology. So we only know the 2 points really well. Is okay, we know that this person was diagnosed, and we know whether or not this person survived 5 years later. We don't really know all those things that went in between, but we do have an obligation to minimize our involvement, to minimize any uncertainty in our parts of the process chain. So while the final, outcome error bar is large, every attempt to minimize it carries through, and it's worthwhile. So while any little thing, any significant or any single intervention is small in its own right, together they add up. Everything counts in large amounts. So each thing that we add, each little thing we improve, it's incremental, and then it can actually lead to something big in the end. So it's our obligation to drive as high quality as possible. So with regard to stereotactic, this is the end of your symposium, your training series of training lectures. So you've gone over stereotactic many times, and you know that it is critical to get it right, because you don't have room for error. There's not 25 more fractions to make up for or to feather out a misalignment. So implementation of IGRT is essential, and it shouldn't be overlooked as just a piece of things. It actually is important in its own right, and implementing IGRT properly carries through to all your treatments, from your 3D to your IMRT and your stereotactic. So these should be a team-based approach, really into systems thinking. So systems thinking, we're not in this alone, and what we do impacts others. So the medical physics or the physics aspects aren't implemented in vacuum, and they should be created in consultation with the physician and with the therapist, and all these different things should be done together as a team. I mentioned this again before, is that the value of process mapping. So mapping it out understanding each element and how it contributes to your overall uncertainty, and whether your imaging protocol, what are you going to use and what's the uncertainty for that. And I mentioned that before about PET CTs, understanding the alignment issues and being mindful for them. And how you're going to define your lung tumor. I think we've come to a consensus at this point. Use a MIP. If you have access to a 4D scanner, you'll use a MIP. You'll use the maximum intensity profile. If you're doing the liver, you're going to do the minimum intensity profile. But understanding how you're going to define your target, and then what you're going to be using for your treatment planning. We use average because average aligns well with cone beam CT, because a cone beam CT is taken over a period of time. So some people use free breathing. Each of the, because they think it has it's less fuzzy. It's got a clearer image. Each of those, whatever you're doing, you should be aware that both of them, those routes, have their uncertainty associated with them, and determine what's acceptable to you. And if using the average works for you, you should use the average. If you're going to do something else, understand what the pitfalls of that are. If you're doing SRS for brain, not all MR protocols are the same, and I think we're pretty clear on that one. And just on the basis of T1, T2, you think of bright eyes or dark eyes. The soft tissue contrast can be dramatically different based on the MR protocol you use. And for brain imaging, there are some other fancier protocols, MP-RAGE, SPACE, that can provide higher contrast and allow for you to actually delineate that target, which is, again, a big source of uncertainty. So being mindful of this when you're setting up your program and determining what's best, and then how are we going to define the target based off of that imaging. I know that different physicians look at T2 imaging and how that's highlighted and how that shows up differently. So that goes back to the value of peer review and discussing how those targets are being delineated.
So Peter, there are a couple of questions before we move on. Someone was asking why for liver cases would you use the minimum intensity projection, while for lung you will use the maximum intensity?
So it's about the contrast. So in the liver, the contrast is flipped. So the lung tumor shows up as white. So, and it shows up as kind of a high density object. In the liver tumor, it's the opposite. The tumor actually shows up less density as the liver tissue. So using the minimum intensity profile allows you to get a better visualization of the liver malignancy. So it's just about the tissue type and the contrast. And that's kind of what I was just trying to pull out, that like one size doesn't fit all. So if you're going to use the minimum intensity profile to quantify all your movement, that might not be the best one, depending upon the patient anatomy. So being mindful of that, and being mindful that, again, one size doesn't fit all. And we don't treat lungs the same way we treat livers or the same way we treat prostates.
Thank you. Another question was regarding the for brain. They were asking what MP-RAGE and SPACE are.
So I'm not an MR physicist. I'm pretty sure MP-RAGE is a T1, but it's the specific pulse sequence. I can't give you that, but I can. This paper right here actually will give you more details on the image sequence. So this Putz et al. 2020.
Thank you. And I will just make a quick comment. I'm not sure if all MP sequences are 1 millimeter thick, but I feel like all the ones I've seen at least were. So I don't know if that makes it also improving.
Oh yeah, and that's a good comment, and we're actually going to touch base on that too. That's why actually in the last discussion we talked about interfacing with outside groups, whether that's IT or referring physicians. It's also radiology, because radiation oncology and radiology are sometimes separate groups. So if you're going to be using an MP-RAGE for your stereotactic program, ideally you're going to interface with those MR technologists to develop that protocol so it's appropriate for you. You don't want to just use something out of the box because it, just like Sarah is implying, it might have a 3 millimeter slice thickness, and that's not ideal for your treatment. So this is going to kind of exactly what Sarah was mentioning. Slice thickness is a critical element. So on the left, we've got 1 millimeter, a target that's defined with 1 millimeter, and on the right, we've got a target that was defined with 3 millimeters. You can see here that this is some significant variation, especially if you're dealing with a small lesion in the brain, and whether or not you're using a margin or if you're relying on dose fall off. So we want to reduce our uncertainty as much as possible, and this is really a low-hanging fruit in terms of the planning imaging is to get small slice thicknesses, and nothing comes for free. The getting a bigger image stack will increase your processing time, and there may be some trade-offs there. But I think this is kind of a dramatic, but this is what happens. So when you use a larger imaging, there's volume averaging, or larger slice thickness, there's volume averaging, and in this case, it elongated the tumor. So we want to reduce everything that we can control. So we want to account for all these things that we can control for. I mentioned this again earlier, is the multimodality imaging, multimodal, whether it's PET CT or CT MR, can be misregistered, and even a good registration has an uncertainty of about 1 millimeter. So knowing the kind of and being sure that this is done properly is really essential. And just verifying these things and looking at these things, keeping your eyes open, and that's a big part of the prospective quality control. You're looking at where errors could occur so that you're more mindful when you're going through that process step. So if I know, and I've built it, I've hit it into my brain that image fusion is a large point that where an error could occur, I'm gonna be more mindful at that point. And that's just what it's all about, is knowing where those critical points are. And here showing that this PET CT, and showing them these are the way these are registered, they could be misregistered, and it actually does happen not infrequently, where with the PET CT they do the CT first, a patient coughs, and then they're on the table for their PET, and that cough caused the misplacement. So in Eclipse, I've had to break the registration and re-register. This is just something to be mindful and look for. I mentioned this before too. Again, I kind of have a repetition to a lot of things that I talk about or share, is the contouring uncertainty. This is showing.
Sorry, I'm going to interrupt you.
Yeah, nope.
Joy has mentioned that it's still not clear to her regarding the MIP and the minimum intensity projection. I don't know. Have you gone through it before, like how the MIP is created and how the minimum or average intensity is created, or has it not been mentioned?
No, I didn't mention that.
I think we covered this in the earlier sessions. So those are all in the Google Drive to access and review. I think the question is for IGRT. It's a little confusing which one is used for which disease site. I think my understanding, and I think I would agree, for lung, often using the mean or the average intensity projection is good for matching your cone beam CT. Since your cone beam CT is taken over time, it's going to look the closest out of all of those options. It's going to look the closest to the average or the mean intensity projection. And that might be one of the most important things to consider. For liver, I think liver and pancreas is probably the other one where it's tricky because there's diaphragm movement. And if you're trying to match up to the tumor, which is very hard, but because the tumor is hard to see in the liver and in the pancreas, but if you're trying to align to the tumor, I think Peter was saying that you could use the minimum intensity projection. However, that is hard, and it might be better to try to line up to something else that you can see clearly, that is next to the tumor, like one of the major blood vessels, for instance, the celiac artery or the superior mesenteric artery, or if there's a fiducial marker. even better. That's easy to see. I hope that helps clarify things, Soha and others.
Well, I'm a bit confused now because I thought when we were talking about the MIP and the minimum, it was more about creating contrast for when you're either contouring or creating a plan rather than for the image guidance part, right? For the alignment part, right?
Right.
Okay.
I'm going to make a little video that I'll share to explain how to do like 4D CT contouring. And I think that'll help clarify the point for the contouring part.
Yeah.
I think this course has really helped me understand what are the areas of confusion so that RCC can help clarify these. So really great questions.
Absolutely. I mean, and that's the thing. If this is a fuzzy point, then it's not you. We're the educators. So we'll work on explaining that in a clearer way. But Sarah was right in terms of, I was referring to contouring for the MIP. I agree completely with Ben. Average is best with a 4D or with a cone beam CT for matching. So, but yeah, this is showing some of the points that we need to focus on to ensure that there's consistency in our practice. And this is the contoured uncertainty with the same imaging protocol. Imagine if you're using different imaging protocols, or people are using different imaging protocols. This is 8 physicians contouring 14 metastasis. And this is also showing the different dose distributions that are received based on these different contours. So there's a lot of variability in the way these things are contoured, and some people see here there's an adjacent cystic region. Some people contoured that, some people did not. And this is also dialing in the importance of the value of physician peer review, checking contours, checking target contours. So peer review is a big thing. So it's second check everything. Here's some more on that specific element is actually there's consensus guidelines on some of these contours where they've had a whole group of people work on this. I think this is actually I think it's a multi-institutional study, but it may be led by Cleveland Clinic, where they were looking at the spine contouring, and you can see some variability in the contours. And then what they did is they defined what the consensus was, what people agreed upon, and they used this as to give kind of guidelines. Obviously, an individual's hand motions are going to be a little different, so the contour is going to be always going to have a little bit of, it's not going to be a clean edge. But this gives an idea whether or not to include this pedicle or whatnot. So peer review again, and getting that contouring uncertainty reduced is important. And this is also showing the difference in what's visualized with the different in the different planes. So how you're looking at things and the imaging protocol that you selected to look at it with are really important. So the grid size is also critical for calculations. So how you assign the dose calculation grid and you overlay that onto your imaging grid, that really can change things. This can really lead to some significant differences. And those it's important to note that those imaging and dose grids are often offset. So that can lead to volume averaging, especially when you're talking about stereotactic and small volume targets. So using a dose grid, I like to say match the dose grid to your imaging resolution. So if you're using a 2 millimeter slice thickness, use 2 millimeter dose grid. But if you're using 1 millimeter slice thickness, use a 1 millimeter dose grid. But the big thing is being consistent and also looking out for these things, being aware so you can look out for these things. Again, the process mapping, how important it is to be able to know where the errors could occur, and then to make sure that you're being mindful. The biggest thing is, when the rubber hits the road, to use a colloquialism, the day of the treatment, that's the biggest step, because that's when you can't turn back. It's a point of no return. So with imaging, there's several different isocenters. The imaging system is only one of those isocenters. So we use the Winston-Lutz to ensure that everything's aligned. But but being aware that there is uncertainty in that, and how you assess that is important. You should assess that. You should set up your Winston Lutz, I do, to also assess your imaging. So I cone beam the BB, set up the BB, and then deliver the treatment to the BB, because this is what we're doing with the patient, and that should be within a millimeter. Or if you're doing SBRT, the tolerance may be a little different. So this is the Winston Lutz. There's lots of different tools for it. The principle is the same. It's a BB set at isocenter. How you set it up at isocenter. If you're using the lasers for targeting, sure. But if you're using imaging for targeting, you should set it up with the imaging. That's my point with the cone beam, because you're setting up the patient with the lasers and getting them close. But then you're ideally fine tuning that with your imaging. So you should do the same thing with your test, so that you have an idea of what your uncertainty is. So that's why I really stress positioning it with image guidance, so that you're getting an assessment of your overall treatment delivery system. Nowadays, more and more, we're moving towards treating multiple metastatic lesions, and this is not the same. You can be perfect on isocenter. That doesn't mean that you're going to be perfect 3 cm or 10 cm out. In fact, they've shown that the further out you are from that isocenter, the greater the uncertainty there is. And to that regard, there are tools to test that. This is a Sun Nuclear tool. There's RT Safe, which uses gels, but this Sun Nuclear tool has multi-target, and you're essentially doing several different Winston Lutzes. By assessing our systems, what we've realized is that our margins are different. We increase our margins the further we are from isocenter. So assessing how good you are at the distal portion is important. So what you're getting at isocenter isn't necessarily what you're going to get 5 cm out. And I can confidently say it's not going to be the same. So assessing that is important. There are a lot of, like I mentioned, there's lots of different ways to do these tools or these tests, and I think you get extra points for creativity. This was done at University of Iowa, where they built a tool with Legos. So Legos are famous because of their precision. They spend a lot of money and time on quality control so that the pieces always fit together perfectly. Like the Lego doesn't have a patent, so maybe you played with Mega Blocks or you played with something else. Those ones don't always fit together quite as nice. The thing that the Lego sets Lego apart is their quality control. So that's what they took advantage of in this paper, in this study, and he wrote his own tool to verify isocenter with a Lego Winston Lutz test. So you could make a Lego multi. You could make a Lego in that test. So for stereotactic, IGRT is most powerful when used under direct supervision of a radiation oncologist. This is not disparaging to my professional colleagues, radiation therapists and technologists. They're great, but physicians really do know anatomy. They know it really well. And so when they're there looking at the anatomy and understanding that patient, that having a full awareness of that, they can really help in getting the IGRT set up properly. So we mentioned this before, whether it's offline correction, online correction, or no correction, the errors are different. And online correction is quickest when the patient or when the physician is at the treatment console. And that's why it's a recommendation, or it's guidance, and actually in some respects it's required in the States. So the utility of IGRT has been shown previously. We've been talking about that, but it's dependent on clear instructions. And that's again, like, what are you aligning to? Are you aligning to the rib? Are you aligning to the soft tissue? Which one's, and what you might be most concerned about in this case is rib toxicity. So maybe that's what you want to have the most, you want to have consistency in is what you predicted to be your rib tolerance. Or maybe it's actually, because you see here, this one's still encompassed in the PTV, it's still encompassed in the expansion, but we want to make sure that whatever it is that we're focused on, it wants to be clear, and we want to make sure that the physician has outlined this properly. So here, showing the bone matching versus tumor matching, and how it aligns in the target. So the daily image guidance, those cone beams, those often these protocols can be further optimized. And whether or not you're going to use a low kV or a high kV, lower kV is going to give you more contrast. It's also going to give more dose. You can optimize the treatment instead of just using the black box, what comes out of the box. You can optimize this to get better clarity, and that's what you're seeing here is iterative optimization, where they improved the imaging on and this last one, this third one is pretty comparable to the SIM-CT. So this is where they're kind of changing the MA and also whether or not a half or a full scan. Again, know your uncertainty. Assess your uncertainty. Know where things can go wrong. Work to control what you can. So we know that for a range of IGRT solutions, the uncertainty is on the order of 1 to 2 millimeters, and accuracy of 2 millimeters. And this is so what you should be able to hit, and you can really check that you're getting it within that range with the end-to-end testing. So that should really show you that you're getting what's achievable. And if you're not getting what's achievable, then look for ways in the chain that you can improve. I think I talked really fast. I'm really sorry if I talked too fast. But the imaging, especially on online IGRT, is an invaluable tool. It allows for real-time quality assurance. And the use of IGRT should be used in light of the big picture. And that big picture is knowing all of our uncertainties. And here you're seeing kind of a review where action limits are created, and knowing, what's my capability, how good can it get, what should be investigated, and what's just normal variation. So you learn these things by studying your treatments and your processes.